Hello and welcome to this program titled Innovations in Type 2 Diabetes and Excess Cortisol, American Diabetes Association Highlights and Key Clinical Pearls. I'm Dr. John Anderson. I practice internal medicine and diabetes at the Frist Clinic in Nashville, Tennessee. And I have two colleagues with me today, and I'm going to let them introduce themselves. John, I'll let you go first.
Yeah, I'm John Buse. I'm a professor of medicine at the University of North Carolina in Chapel Hill, and I direct the Diabetes Center.
And Vivian.
Hi, John. I'm Vivian Fonseca, professor of medicine and endocrinology at Tulane University School of Medicine in New Orleans, Louisiana.
Well, welcome to you both, and thanks for doing this program with us today. At the most recent American Diabetes Association meeting, there was some exciting new data presented on the management of patients with hypercortisolism or Cushing syndrome and cardiometabolic conditions such as type 2 diabetes or hypertension. Today, we're going to talk about the management of these patients and really the clinical implications of this new data. So Vivian, I'll let you go first. Can you talk a little bit about the clinical consequences of hypercortisolism or this Cushing syndrome?
So we are taught in medical school how important cortisol is as a hormone. It affects almost every system in the body, and we need it for life. But if you have excess, it's a problem. And this excess commonly comes from exogenous sources. People use cortisol-like drugs for a variety of things, for joint pains and acute viral illness. But if it's used chronically, it has consequences. And at its extreme as a disease, hypercortisolemia is well known now as Cushing syndrome, which was described related to pituitary and adrenal tumors that had very high levels of cortisol, a lot of manifestations in almost every organ of the body, but essentially weight gain in central obesity with menstrual disturbances, osteoporosis, often severe hypoglycemia and high blood pressure, as well as immune suppression. What we're recognizing now is not the full florid Cushing syndrome, but the disease is a spectrum. And what we described at the ADA meeting was people who have milder degrees. You wouldn't recognize them or think about Cushing syndrome, tumor-related Cushing syndrome, if we saw these people, but they still have an elevated cortisol level, which might have consequences.
Okay. So, John, what do these patients look like? I mean, how do they present to the office? Is there one feature or is this a variety of features?
Yeah, I love the way you asked that question. What we're talking about today is not the classical Cushing syndrome, which we learned about in school with facial plethora, easy bruising, proximal myopathy, violaceous or purple stria across the abdomen. There is no look to this hypercortisolism that's important in diabetes and cardiometabolic disease. What we're talking about is associated at most with subtle clinical features. And I think the listeners are seeing a slide of a woman who maybe her face is a little bit plumper than average, but really she's very sort of average appearing person. But what's different about these people is they have multiple comorbidities of diabetes and cardiometabolic disease, as Vivian outlined. The usual pathophysiology is autonomous or ACTH independent cortisol production by the adrenal gland. And what we found out is much more common than we previously thought.
So Vivian, in your experience, these patients in practice, how do they come in looking to you when you see these folks?
So my experience has evolved over time. Like most of us who train in endocrinology, I've always been looking for Cushing syndrome, somebody who has a lot of weight gain, and we test for it, and very rarely do we actually find it. People with striae, which may relate to rapid weight gain. But a few years ago, reports from Europe suggested that milder degrees of hypercortisolism are more common, and these people may not have all those florid symptoms that John was describing. So I started looking for it, and then, of course, we've done the Catalyst study, which we specifically looked for that population among people with poorly controlled diabetes and found it to be much more common. So it's important to recognize that hypercortisolism is a continuum in a spectrum from severe Cushing syndrome, the most severe being adrenal carcinoma or ectopic ACTH syndrome. But there are also people with very mild disease clinically, except that it might have metabolic consequences.
Great. So, John, these patients are much more common than previously thought. I mean, obviously, our understanding has evolved. Can you kind of explain and maybe perhaps talk about why that led to the Catalyst study?
Yeah. So as Vivian mentioned, there was some studies done outside the United States that were modest in size and different in the ways that they were designed that suggested this hypercortisolism thing was more common than we thought in the setting of poorly controlled type 2 diabetes. So we did the Catalyst study. We defined difficult to control type 2 diabetes as having an A1C greater than 7.5 up to 11.5. So we didn't have people that were just metabolically a total wreck, which can be a stressor and perhaps have artificially raised cortisol. But anyway, people with difficult to control type 2 diabetes based on an A1C greater than 7.5 on 3 glucose lowering medications or 2 glucose lowering medications, with one being insulin, or 2 glucose lowering medications and 2 blood pressure lowering medications, or 2 glucose lowering medications and evidence of complications. The test we did was very simple to do, an overnight dexamethasone suppression test. So people take a 1 milligram tablet of dexamethasone at 11 p.m. and then have their blood drawn for a 8 a.m. cortisol and an 8 a.m. dexamethasone level. The dexamethasone being just to make sure that people took the tablet, that they absorbed it, and they aren't rapid metabolizers. And if the result of that morning cortisol level was greater than 1.8, that was hypercortisolism. What we found was that 23.8% of over 1,000 patients that we tested had hypercortisolism. The people with hypercortisolism had more cardiovascular disease. They had a higher overall medication burden, including blood pressure medicines, fibrates, analgesics, and they tended to have characteristics that were a little bit unusual or maybe counterintuitive. If anything, they tended to have lower BMIs. So they had some disease process that went beyond obesity, and they tend to be on the most novel and powerful drugs. So they tended to be on SGLT2 inhibitors, GLP-1 receptor agonists, and tirzepatide.
And despite that, still not under control for their type 2 diabetes.
Exactly.
So Vivian, as investigators, when you're starting to look at this population, before you saw these clinical trial results in Catalyst Part 1, what was the general thinking among the investigators about what the prevalence or incidence of this would be?
It came as a big surprise. We thought it would be somewhere around 8 to 10%. So this 23% really surprised us. But I think it's important to recognize that this is aligned with what has been previously described in Europe in smaller studies. So this is a first large-scale study and the first one in the US population. There are a few other little things that it's important to recognize in relation to Catalyst. We chose the cutoff for dexamethasone suppression as being abnormal, of being 1.8 or greater. And that is actually aligned with data from Europe that suggests that if you don't suppress below 1.8, you have worse outcomes over the next 10 to 15 years. Secondly, we measured dexamethasone. That confirms that the people actually took their dexamethasone. So just to tell you what the results showed, the mean cortisol level following dexamethasone in the study was 3.5. So there were clearly many people with abnormal results. And the dexamethasone level was also well over 300. So you're talking about people who took their dexamethasone the previous night, still had it in circulation, and really should have been suppressing their cortisol. But as John pointed out, these people had taken every possible medication out there that's available. And on top of that, many were taking insulin plus a GLP-1 plus a SGLT2 inhibitors and still were not controlling their diabetes well. So it really was surprising. Another surprising finding was that we did CT scans on all these people who were positive, and a third of them had abnormalities in the adrenal gland, including some with single tumors or some with bilateral tumors. When you think about it, these were people going to many academic clinics, and nobody had thought to screen them for hypercortisolism, and they had something that basically could be surgically curable.
How about that? So John, as you start to look and sort of inform our audience, especially in the primary care community, who do you start to think about screening for suspected hypercortisolism?
It's a great question. So I'll tell you the gestalt that I have developed is the patient that you feel like, you've done a good job trying to manage their diabetes, where you sort of feel that they're earnest in their pursuit of good glycemic control and better health. That's just not getting where you want them to be. Their hemoglobin A1C is higher than you might like. They may have more difficult to control hypertension than you might like. They may have had more complications than you thought that they really deserve based on their lifestyle efforts, et cetera, et cetera. It's basically the difficult to control phenotype that we talked about in the beginning. I think a lot of times if you sort of have in your mind that maybe this patient's not being adherent with the treatment plan here, bad diet, no physical activity, maybe they're not taking their medications. If you start to ask yourself that question, you should be thinking about hypercortisolism as the actual problem. Give them a chance to confess that they don't take their medications at all. But I do think a lot of people that we previously considered as non-adherent probably had this hypercortisolism. A couple of things that we didn't look at in the Catalyst study specifically would be people who have unexpected fragility fractures. That might be another population that you would look at, or people that just seem to have this sort of overwrought nature. They're anxious. They're always troubled by this, that, or the other things. You're having these slightly bizarre, uncomfortable conversations with people. The psychiatric overlay of hypercortisolism is really heavy. And then lastly, if you have patients that are taking 10 medications and not doing perfectly well, that is something that should make red flags go off and consider screening for hypercortisolism. Basically, it's probably a pretty big portion of the patients in your practice should be screened if we think about the population average A1C in the United States being about 7.5 or 7.6%. The test that we used was really simple to do. Now, not as easy as, measuring creatinine, but it's a single 1 milligram overnight dexamethasone suppression test. To get into the treatment phase, we required on another day a morning ACTH and DHEA sulfate or DHEAS to confirm that the source of the hypercortisolism was the adrenals. And then we did the adrenal CT, which, as Vivian pointed out, among the people with hypercortisolism, a third had CT abnormalities and were theoretically surgically treatable. And importantly, and probably the most important thing, is we excluded people from participation in the trial if they had a common cause of a false positive dexamethasone suppression test. So people that were using oral contraceptive pills, people that drink more than the recommended amount of alcohol, people with severe untreated sleep apnea, severe psychiatric, medical, or surgical illness, night shift workers, and people with end-stage kidney disease on dialysis or otherwise.
Well, I think that's helpful because those of us in the primary care community now have a picture of those frustrating patients. And as we look back at our careers, how many patients may we have missed over the years that we just sort of chalked up to non-adherence or other reasons for not being able to get them under control. Vivian, so let's talk about part 2 of Catalyst. At the American Diabetes Association Scientific Sessions recently, both of you presented part 2, or the treatment phase of the Catalyst study, and I'd love it if you could run through some of the highlights of that.
So people were eligible for part 2 if they met the criteria for diagnosis of hypercortisolism, which we just defined, and were willing and able to take mifepristone. So there's some contraindications. Those people were excluded. So we took these people, randomized them 2-for-1 to mifepristone or placebo, and we followed them for 6 months. And the primary endpoint was a change in hemoglobin A1C. And to everybody's surprise, the A1C in the mifepristone group fell by about almost 1.5%, 1.47 or something. But there was a small drop in the placebo group as well. So the placebo subtracted change in the mean A1C with mifepristone was 1.32%, which was statistically significant. Now, the dose chosen was escalated, starting with 300 milligrams and then going up to 600 milligrams. And people had the option of going to 900 milligrams, which a few people did. The response overall was very good. Some people started getting hypoglycemia, especially those on insulin. They were able to reduce their insulin doses, particularly prandial insulin, and in some cases stop. Some reduced their GLP-1 receptor agonists if they were having side effects and discontinued. So overall, in terms of improving glycemic control, there was a good result. There were some adverse events, particularly tolerability in the form of so-called steroid withdrawal syndrome, which is seen with anybody who has hypercortisolism and then treated. And you see it when you withdraw steroids from people. You feel fatigue, some nausea, vomiting, some headaches. That did occur, and some people dropped out of the study as a result. There was a small increase in blood pressure in a few people who had a baseline of 125. It went up to just under 130. No changes were made in most of them with their blood pressure management. And hypokalemia is a well-known side effect of mifepristone, also occurred in a significant number of people. So those were the major side effect issues.
Okay. So John, this data, what do you think this means? Again, translating this back to day-to-day practice for these patients that are difficult to control. How do you now think differently about those patients?
Yeah, I mean, I think this is proof of concept that we should be screening for hypercortisolism because we can find something that's treatable. Now, we haven't talked about surgical management. Some people, that wasn't part of the Catalyst study, but, a third of these people, or at least a quarter, might be surgical candidates. Mifepristone turned out to be extremely effective for hemoglobin A1C reduction. Was also associated with clinically significant weight loss, about 5 kilograms over the 6 months of therapy, and the weight was going down. So we don't really know how far the weight loss would go with continued treatment. An issue is this is not the easiest medication to use because of this glucocorticoid withdrawal syndrome that Vivian discussed. And also the hypokalemia. And that was made particularly challenging in a randomized trial where we didn't really know who was on drug and who was on placebo. So in clinical practice, that piece of it might be easier to do. But the important thing is we have to recognize these patients because it's such a bad sort of feeling for patients to know that they're doing their best in their diabetes management. They're just not getting there. They fret that their family thinks that they're not doing what they're supposed to do, that their doctor doesn't think that they're doing what they're supposed to do. It's such a relief to patients to understand that they just have something different that needs a different approach. It's been one of the most gratifying clinical experiences of my career to make the diagnosis of hypercortisolism and difficult to control type 2 diabetes.
Right. And Vivian, I'm just going to throw a second question out there. What's the consequence of those of us not diagnosing this? In other words, these patients continue to have hypercortisolism. What does their future cardiovascular risk look like?
Well, many have already got cardiovascular disease, including heart failure and atrial fibrillation. So I think that is a problem. And the description I gave you of people above 1.8 and having poor outcomes, the majority had cardiovascular events. Now, that's a bit of extrapolation. We don't know what's going to happen to this population here in the US who may be having aggressive cardiac risk-lowering therapy. But even so, their diabetes is very much out of control. So they're at very high risk of diabetes-related complications, both microvascular and macrovascular. So I think there is things that we can do to prevent that. And the problem is they've tried all the magic medicines we've got right now, and it hasn't worked. And, here is a solution but we need to explore it carefully, trying to minimize side effects and making the drugs more tolerable to these people. And I expect that we will be looking for newer approaches to treat hypercortisolism over the next few years, now that we recognize that it's a significant problem in practice.
So from a clinical standpoint, I think the message to those of us who are on the front lines of taking care of people with diabetes and hypertension is to be looking for these people. It's easy enough to do, as John described, the overnight 1 milligram dexamethasone suppression test. It's easy enough to get subsequent DADA and ACTH levels. What then for the clinician who's not an expert in this? Would this be a referral, John? What would you expect to happen as the next step for these patients?
Yeah, these are very early days in the thinking and approach to people with hypercortisolism in the setting of difficult to control type 2 diabetes. Remember we have hyperaldosteronism, Conn syndrome as a cause of resistant hypertension. It's been described for, I think, over 50 years. And still that's an evolving area with new guidelines published just in the last month. If you have access to an endocrinologist that's facile with using these medications in the setting of ACTH independent hypercortisolism, adrenal-based hypercortisolism, that's ideal. Just refer them. People who have a lot of experience in managing the glucocorticoid withdrawal syndrome are just going to have so much of an easier time. I will tell you that I had never prescribed mifepristone before I participated in this study. And now I have a couple of patients that are under care. It is something that you can learn how to manage, but it is a rocky start because of this glucocorticoid withdrawal syndrome and the hypokalemia. But I'll tell you, it's easier in clinical practice than in the clinical trial because you know upfront what's coming, and you can proactively treat patients with spironolactone to prevent the hypokalemia and to really counsel people up on the glucocorticoid withdrawal syndrome, some of the things that could be done to mitigate some of those symptoms. But this is not the easiest medication to use from a primary care perspective or from a specialty perspective.
So Vivian, it sounds like there's a whole lot of discussion that has to happen with these patients ahead of time to set some expectations of what treatment's going to look like.
I agree. I think even from a specialist and research perspective, this is work in progress. We need to learn how to minimize side effects, how to make dose adjustments that will lead to better outcomes, and look for other solutions should they become necessary. An important thing is who should have surgery and who not to. I wouldn't take bilateral adrenalectomy lightly. That's not what I'm recommending. But I do be doing more and more venous sampling to see if one side is a dominant side and then consider that. I go back to what John said. We've known about Conn syndrome for 50 years, but it's only in the last 10 years that we've recognized how common it is in resistant hypertension, particularly in people with diabetes. And I see a couple of patients every month with newly referred hyperaldo. And I expect I will see hypercortisolism as well at the same rate soon.
So, as we start to go ahead, John.
Yeah, I was just going to add in there, one thing that's evolved in the hyperaldo story is, we used to be all about making the diagnosis and then treating those patients, either surgically or medically with something like with a mineralocorticoid receptor antagonist. But now more and more of the guidelines are just saying if people have resistant hypertension, treat expectantly with a mineralocorticoid receptor antagonist. And I do wonder, the one thing that we didn't look at in the Catalyst study is there was another 25% of patients whose cortisols were higher than expected, and another 25% that were still a little bit higher than expected. How broad is the hypercortisolism story in diabetes?
Right.
Is it contributing to most people with diabetes, or is it really just a quarter of the poorly controlled people?
I just want to add one thing, John, in the results thing, and that is there was a good response to mifepristone in people with and without, equal response, with and without adrenal nodules. So this is the first description of a treatment of blocking cortisol in people with what is called neoplastic hypercortisolism. That means they have a tumor. You could treat them surgically, but if it's bilateral, that's challenging, and not everybody's fit for surgery. Here you do have a solution. How long you do it, these are all, I don't know. These are all unanswered questions. Another thing I can tell you is that because of the hyperaldo, we are doing more and more venous sampling, and we have a couple of interventional radiologists who become very adept at it. We're doing it, it's not a difficult procedure to them.
Okay. Well, we've got time for just a couple of questions. One has come in, and I think this is a practically useful. So I'll toss this day up to either John, Vivian, either of you. What about the patient you've screened and they're not above 1.8, but they're just below it? In other words, truly not normal, but not meeting the threshold that we saw in the Catalyst trial. What would you do? Is this someone you recommend retesting in a year? Is this someone you continue to follow? What would your advice be for the primary care community?
Yeah, it's a tough question. We conducted the study in a certain way. We don't really know whether mifepristone would help. I do think, in general, the story is that people with this ACTH independent hypercortisolism, they don't tend to progress. I mean, the expectation isn't that if it was 1.7 this year, next year it might be 1.9, but that is certainly an approach that you could use. One problem is the mifepristone in the formulation that's approved for using in the setting of hypercortisolism is very expensive, and it might be hard to get the drug approved if you didn't have an official diagnosis of hypercortisolism. That said, you would certainly want to treat them expectantly, understanding that hypercortisolism is probably part of their pathophysiology. Worry a bit more about their bones and cardiovascular disease, and using drugs like mineralocorticoid receptor antagonists.
Vivian, I'll tell you this because we're coming down to the end of our program here today. One of the questions came in is, we talked a little bit about the mental health and the depression part of this in patients. Do we see that improving as we treat that patient population?
That's a very good question that we didn't look at. A significant number of people in the Catalyst study were taking drugs like SSRIs, etc. The trouble is a lot of people with diabetes take those kind of medications. Depression is a feature and a risk factor for diabetes and its progression. So we didn't really look at that carefully. I think that's something that needs to be done, just like looking at their bones as well. These are all things that open up avenues for further research for us.
I might just mention that a clinic patient that I treated outside the study, one of the main reasons I pursued the diagnosis of hypercortisolism was she was just overwrought, anxious, and that was just remarkable how much better she felt and seemed on mifepristone.
Well, I want to thank both of you, John, Vivian. Thank you for joining us. I want to thank our audience for joining us today, and thank you for participating in this activity.
It was a pleasure.
Thank you.